what I was under the impression of still when I was on the plane just a few hours ago, was that I was supposed to give a 20-minute talk and that I was supposed to talk about translations. That's what I'm going to attempt to do. I took out slides that related to how work related to serotonin could be translated, which I think would be an interesting point for the discussion. Randy's wincing in the back. Also took out slides related to very early impact of serotonin development, including the maternal serotonin system. So instead, I'm going to sort of talk about translation. Just looking at the conference, it feels like there is a lot of crosstalk, because I wasn't here till now because I was at an advisory board for the Simons Foundation and then at an event last night. I didn't get to see all that, so forgive me if some of this is redundant with earlier perspectives. I'll do my best. Disclosures, I'll note that I am going to talk about some work that was funded by Roche that will pop up and should be fairly obvious, as well as reference some work funded by Novartis. None of that has come to market, but just to note the disclosures. And then also want to note that because this is intended to be translational, it's fairly conceptual. And so I'm not going to call out individual members of the lab, and in fact, a lot of the work is going to span into work from other labs, and I'll try to highlight that, but I'm not going to call out every individual. What I'm going to try to cover is something that I think has already been covered in a way here, the challenge of heterogeneity in autism, and then really focus on how we've tested treatments and how we are attempting to find new treatments. I'm going to highlight the precision medicine sort of approach because it seems like that's part of what gets talked at this conference. It's my first time attending. I'm going to leave out the other approach, which is sort of thinking about autism writ large, although I'd love to talk about that more, either in discussion or over dinner or breakfast or lunch. Ultimately, I don't think that we're going to be talking just about precision medicine. I think what we're ultimately going to be doing is putting together treatments that change brain function with interventions that actually, behavioral interventions that actually make use of those changes. And so I'll talk about that very briefly at the end. I'll note that this conference is focused on autism, but when I see somebody with a diagnosis of autism in the clinic, sometimes that's the problem that's in the center, but sometimes there are other problems in the center, and I think we have to keep that in mind when we're thinking about potential outcomes. Sometimes GI function is the easiest thing to target, and we have to be very careful about where we think we're intervening and what we think the outcomes are likely to be. I will say that there are, when we talk about precision medicine, there are models where you think about sort of this ball pit where everybody has a different color, and you try to find enough people with the same color and treat them with a common intervention. I will say there's another model, which is to realize that across individuals, there are differences across multiple domains. And so in autism, you can think about repetitive behavior and social behavior as two domains, but there are lots of others we could be thinking about. And just acknowledging that as part of our challenge, that there's differences across groups of individuals and then differences in severity even within individuals. The model that we have for risk still favors the concept that there are multiple risk factors coinciding in individuals, likely some of those common. We don't have great examples of those, either environmental or genetic. What we have, and what I'm going to use as an example here, are quite a number of rare genetic syndromes that contribute most of the risk for individuals. We also have some examples in the environmental domain, like exposure to valproic acid in utero. There are a few other examples. Some of these coincide. We heard about mTOR signaling earlier. I think that that's appealing to think about. It hasn't been clear yet that those will translate, but I think it's intriguing. I also think it's worth noting that in quite a number of examples, we have developmental risk either from loss or gain of the same gene or gene region. You can imagine the challenge there when we think about treatments that might translate from a small group of individuals into the overall group of individuals diagnosed with autism. When we think about translating risk from genetics on up, we're essentially looking at genes all the way to cognitive and behavioral domains, what we're using to make our diagnoses. We also have to respect the fact that the impact here may be at a very different point in development where we're actually ascertaining the individual, and that's an additional challenge. We can expect that things are going to coalesce near behavior because that's how individuals are identified for genetic studies. It's very logical. Thus far, most of what has coalesced is much lower down, protein networks to a lesser extent, individual cell types, with considerable uncertainty in between. This is the uncertainty upon which all of our current treatments are based. So this is a pretty big improvement, but still not where we would like to be. So, sorry, I don't know why that forces me to click through again. My apologies. So I want to just very briefly talk about what we actually know about medication interventions. And part of this is, most of this is quite disappointing. So I'm going to use the example of secretin, which is the answer to this question, that other than oxytocin, it actually has the most randomized controlled trials in autism, and has strong evidence for lack of efficacy. It's easy to talk about because no one thinks this works anymore. And the reason no one thinks it works anymore is what was discovered when people finally did randomized controlled trials in autism because of the excitement around secretin. And what they found was, and this is a total score of autism symptoms, you could put many different measures on that axis, but you can see here that the placebo response is really dramatic after receiving an infusion of what is essentially saline. And there is also a response to secretin, but it's not as good as placebo in this instance. Prior to this, people thought open label treatments in autism were really a good way to evaluate because people thought they knew, that autism didn't improve. And so if you saw an improvement, that must be a benefit of treatment. But in fact, that does not clearly seem to be the case. All of what we know about medications that lead to benefit is for associated symptoms. We're all familiar with improvements in irritability and agitation symptoms. I'm putting up one of the larger studies here from Marcus and colleagues looking at aripiprazole to show you that there too, even when you're looking at pretty severe tantrum behaviors, aggression, self-injury, you can see a substantial response to placebo here at the top versus obviously a superior response to active drug. But this is to say placebo is a challenge all around. We also know that treating ADHD and autism spectrum disorder can be successful, lower rate of response, and here there's actually less placebo response. And then there is some work looking at repetitive behaviors, and that work in adults actually shows that serotonin reuptake inhibitors seem helpful. Now importantly, in those adult populations, most of the folks who were in the studies met criteria or came close to meeting criteria for obsessive-compulsive disorder as a co-occurring problem, whereas studies in children have been much less promising. And in children, in most of these studies, they lumped repetitive behaviors together. And so saw no significant advantage of a serotonin reuptake inhibitor with some hint of a differential response to placebo. And that's shown here where you see that the placebo response is better across multiple domains for folks, better meaning more response, not what we'd like to see, but more response in individuals who have less severe impairment or distress. So folks who are less affected seem to respond more to placebo, which I think is one potential hint as we think about study design. In work that was originally funded by Roche to do the clinical trials, a group of us, looked at placebo response predictors across really the largest population in which this has been evaluated to date, 3 clinical trials. It doesn't actually matter what was on the other side. It's a vasopressin receptor antagonist. We could spend time talking about that, but it's just useful to think about what seems to drive placebo response in this big population, and actually it's hard to read from the back. The #1 predictor across 12-week trials was that people who are enrolled at commercial sites that are not in academic medical centers, were more likely to respond to placebo than folks who are enrolled at academic sites, suggesting that there are challenges at sites who may see fewer individuals with a diagnosis of autism. There also was signal, and sorry, this looked better on the plane, but there also was signal for baseline scores of the measure that was used as an outcome measure. And that we can imagine is always going to be a challenge. In the previous example, I showed you that folks who were less impacted seemed to have a bigger placebo response. In this particular study, folks who had really low scores in social and communication on the Vineland Adaptive Behavior Scales actually did not show much capacity for improvement, whereas those who had moderate scores showed more capacity for improvement, suggesting that it matters what your outcome measure is. If you look at placebo response across autism studies, and this is again from that study that looked at placebo response in citalopram, they then looked across all trials that have been done in autism, or at least all that had been done at the time, you see response rates that on average end up hovering around 30%. So 30% of individuals in trial show the sort of response that clinicians are looking for. This is the much improved or very much improved rating that all of us as psychiatrists, neurologists want to see when we start a new medication. And you can imagine when you have a heterogeneous population, comparing maybe it's 20% of the population that's going to have a specific response against a 30% placebo response could be considerably challenging. So why is there a placebo effect in autism? So part of it is probably sort of the power of belief. We see placebo effects across many domains, and that can be true for things like ulcers, even cholesterol levels, clearly things like blood pressure. And there are different things that drive placebo response that suggest part of it really is belief. The more significant the intervention, the more invasive the intervention, the bigger the placebo response. But placebo also can be thought of as really a control for the nonspecific changes that occur during treatment. And some of that we kind of expect, right? So no one enrolls in a clinical trial when they are at their best, right? That doesn't happen. Instead, we all have natural fluctuations across life, and most people who are enrolling in a clinical trial enroll when they're struggling, not when they've just showed rapid gains. And so we should expect that we're going to see some regression to the mean. We also have to be aware that even in a developmental disorder, you see ongoing development. So you think about that regression to the mean, and then you think about development. This may be typical development. This may be somebody with a neurodevelopmental disorder. At key points, you may see more development happening, and then you may see a point of stability. But we should expect to see change. Development happens. You won't see as much change in adults, of course. You also can expect that there are going to be effects of observation. So if I ask you a question you've never been asked before, you're going to go home and check to see if that has changed in your child, right? And when you come back and I ask you the question, you'll have a more solid answer than the first time. So in some cases, we want to deliver questions a couple of times before we're actually tracking potential change. And then there's the effects of care, right? So if you come in and I ask you some questions and suggest some things, you may actually see improvement that's just due to interacting with a clinician, due to interacting with somebody who's trying to be helpful. Not as big a benefit as we're hoping to see with medication, but still can see significant benefit. So what we're aiming to do is to mitigate these non-specific changes that happen during treatment. Part of that is using a placebo. Sometimes people use a wait list or use other designs. That's actually the opposite of a control. If it's a wait list, you're telling somebody you're not going to change for a while, and then you're going to get access to the study drug. And in particular, even if it's a study of a medication, if there are particular predictable side effects that you're expecting to see with the medication and you don't see them, you're going to expect not to see improvement. You want to blind your raters. You want to use longer duration of treatment. Interestingly, the effect of commercial site was not as substantial once you followed people out to 24 weeks. So if you follow people for a longer time, you're more likely to see potentially specific benefit, or at least not non-specific benefit. And then you want to hold the likelihood of treatment the same across your two interventions. Because if you tell people there's a 75% chance that you get study drug, they're more likely to show a placebo response. And you actually see that in studies that have multiple doses of drugs versus single dose 50-50 randomization. You also want to select outcome measures that are better anchored and ideally objective. And I'm going to talk about an example of that. You also, unfortunately, have to know in advance the range of the outcome scores in your population of interest. So I'm going to show you an example of that, where there was a population that was within a trial that was down here and didn't really have a whole lot of opportunity to make improvement. You want to pick folks who have some room to make improvement on your outcome measure of interest. All right, here we got to click through again. So I'm going to use an example from Fragile X syndrome. We could use other examples. We could use a lot of other examples, but in 20 minutes, that's sort of unreasonable. So part of why I picked Fragile X syndrome is it's been around for a long time in relation, or it's been understood in relation to autism risk for a long time. Importantly, most people with Fragile X syndrome do not have a diagnosis of autism. What is universally seen as intellectual disability. There are other co-occurring symptoms. I'm going to go very quickly through the background because I want to talk about the clinical trial results. But just to note that now for decades we've understood that there's an expanding trinucleotide repeat in the 5' untranslated region that leads to silencing of the gene, loss of the corresponding protein, FMRP. That's an RNA chaperone protein that has quite a number of roles. One that has been extensively studied is downstream of metabotropic glutamate receptor 5 signaling, where you see increased translation of FMRP, and then you see that it serves a role to dampen further signaling downstream that results in removal of AMPA receptors from a recirculating pool. So if you don't have FMRP, you see too much AMPA receptor that is internalized, not enough that's on the cell surface. You see, as a result, an immature appearance in dendritic spines, this sort of elongated Philippodia-like appearance. That's something that can be seen in humans and in mice, beautifully translational. Unfortunately, the mice have mild hyperactivity. They do have abnormalities in the tube test of all things, but they don't have clear behavior that you would expect to translate across species, perhaps except for seizures. Skipping through a lot of work by Mark Baer, Kim Huber, others, I'll note that building on a genetic rescue, a group at Roche was able to show that by tuning down that receptor, they could rescue the dendritic spine phenotype, they could rescue all the behaviors that they looked at. They didn't have obvious ill effects on health. So this is sort of the ideal thing that you want to translate. This is about as high as folks have gotten across this cascade. And then, of course, there is this gap where we really don't know the behavior that we would expect to see. So obviously, we want to see it translate to humans, and this has now been tested. The initial tests, because of both regulatory reasons and sort of convenience, the initial tests were in adults and in adolescents, and I realize this too is hard to see in this light. The gray line is placebo, and if anything, placebo was better than 3 doses of active study drug. And that was true across domains. You could slice and dice it in different ways. Very disappointing. However, the outcome of interest here was quote-unquote aberrant behaviors lumped together, as opposed to learning or something you would imagine might respond to a treatment that would improve synaptic plasticity. So taking a different approach, Liz Berry-Kravis led a group of us to look earlier in development, to look in young children, and to try to delve down a little bit. And I'm just going to tell you about the behavioral outcomes. The rest of the study is still under analysis. Unfortunately, the initial outcomes are also not as favorable as we might hope. But I think it's important to note that this is what we would like to see, but it still doesn't completely fill the gap. Importantly, in this study, we were looking at 3 to 6-year-olds. And we were using a language intervention, which is essentially a parent-mediated language enrichment that is designed to give children an opportunity to show language growth over time. This is a period of time when children with Fragile X syndrome are usually acquiring quite a lot of language. And unfortunately, and I'm just going to show the data briefly, but unfortunately what you see is that, if anything, the placebo in the overall group had an advantage over study drug. In terms of acquisition of language in real-world settings using this weighted communication scale. You'll note that there is not a lot of placebo response, right? So this is an observational measure, carefully blinded. We also had a placebo lead-in which I can tell you now, but we didn't want to talk about while the trial was ongoing, to try to have multiple measures before you actually saw a potential response to either active drug or placebo. And so that probably ameliorated the placebo response. Now, I would much rather be showing you an active response that exceeds placebo. Interestingly, when you dial down, there was an interaction between baseline IQ, and you could measure it in a number of ways, or baseline weighted communication, where individuals who had a higher weighted communication score at baseline actually did not show a particular difference, whereas individuals who were near the bottom, I showed you that bell curve, so they were near the bottom of the bell curve at baseline, actually did better on placebo than they did on active drug. Significantly better on placebo than active drug, which is a little bit alarming. There weren't a lot of adverse events or side effects seen. There was an interference with sleep and kids who showed some sleepiness during the day. So that may be part of what was driving that, but some kids did seem to do better on placebo. We can hope that this sort of intervention approach, the precision medicine approach, yields benefit in things like Fragile X syndrome. We can hope that if this actually did better in the active treatment group, that would also tell us how to study potential interventions in the larger population. I will say, this suggests that this is a way to avoid a placebo response. It also suggests that this mechanism, even though it helps mice, probably is not a mechanism that's going to translate into humans. There is, of course, the possibility that in some ways, identifying interventions in smaller populations, these precision medicine populations, might extend to the overall population. Probably too soon to have much conjecture there. I wanted to very briefly talk about now the promise of short-circuiting the cascade in Fragile X syndrome, where you see the clinical description of the disorder, identification of cause and risk factor, animal model, discovery of mechanism, reversal of mechanism in an animal, and then clinical trials in humans. And that is essentially to jump from gene all the way to the outcomes of interest. And there is a lot of discussion now of doing just that. I will say again, there's likely a challenge up here to know the outcomes that are most likely to change. This is based in part on the incredible benefits that you see in spinal muscular atrophy with an antisense oligonucleotide that is infused during development and shows dramatic improvement in motor function and lifelong adaptive behavior, what we presume is going to be lifelong adaptive behavior. So this, I think, for some of the single gene syndromes that are identified in individuals with an autism diagnosis will be the future. And the future ideally won't be after diagnosis. The future will be based on sequencing-based newborn screening and identification of individuals who are likely to be severely affected by a neurodevelopmental syndrome and would benefit from intervention as early as we can give intervention. There are a lot of open questions about this. This isn't something that we're really ready to do at the moment, but whole genome-based newborn screening is coming. I don't know if it's 5 years away or 10 years away, but that will be what we do to screen newborns in the future. And so working with Wendy Chung here and a number of others, we have an Autism Center of Excellence now at Columbia that is built on top of a whole genome newborn screen that is being done across the Columbia, New York-Presbyterian Cornell hospital system, where 100,000 babies will end up being screened with whole genome sequencing shortly after birth. So based on the same heel stick that's used right now for metabolic screening after birth, we anticipate about 400 out of that 100,000 will have a rare genetic syndrome that is contributing to autism risk. And we hope to enroll 240 of those in a longitudinal study. We want to understand our success in predicting outcomes on the basis of genetics. This isn't what we normally do in autism, right? We normally make a diagnosis, do the genetic testing, and say this leads to that. We aren't usually in the position to actually look at a population level to understand how strongly we can predict. So we make these sort of back translations, but this is actually going forward instead, and there are lots of opportunities there. We also want to understand what this is like for families. This is coming, right? In some cases, this is already happening in families who are concerned about likelihood, say in a second child, or concerned about likelihood because of advanced parental age. So some families are already testing, but we want to understand their experience and how they think about potentially making decisions based on this information. We want to figure out how they're accessing early intervention when they have a genetic diagnosis, potentially before they have any behavioral or developmental indicators. And then we want to follow these kids to understand whether we can predict at 6 months that this child is headed in a particular trajectory versus another child, because we know some of the time kids with these rare genetic variants actually do not end up with an autism diagnosis. We expect some of them will not end up with intellectual disability. And in those cases, we probably don't want to do a dramatic genetic intervention that might have some substantial associated risk. I'm going to stop there. Sorry, this forces me to click through again. And just note the challenge that once we have these sorts of interventions that we think change the brain using knowledge of biology, we still have to figure out ways to put them together with behavioral interventions. And this is really the only example in autism to date where it worked to put a behavioral intervention together with a medication. This is a group where everyone ends up on risperidone. The group in blue ends up also getting a behavioral intervention. This is a measure of disruptive behavior. You see the group in blue does do better. Both groups are on risperidone. They both show pretty dramatic improvement over time. And there is a question whether this sort of juice is worth the squeeze, so to speak, whether it's a big enough improvement that it's worth the behavioral intervention. The improvement also didn't sustain at 6 months, which raises an open question. However, the group that received the behavioral intervention ended up on less risperidone, again suggesting that there are nuances to how we do clinical trials that are likely to be meaningful. You want to set your doses the same in both groups so you actually have an opportunity to see benefit. What we might hope to see is more like the example with D-cycloserine, which is used now somewhat clinically, but has been studied across multiple anxiety disorders, where if you give it right before behavioral intervention, which is based on an exposure and inhibiting your response, your fear response to that exposure, not avoiding whatever it is that you're afraid of, you can see that the D-cycloserine dramatically improves the rate of response, such that if you had an intervention like that and coupled it with behavioral interventions in autism, you could potentially improve the slope of development that kids were experiencing. So I'm going to just put the take-home points up. I realize I didn't succeed in doing this in 20 minutes, but do want to take questions. I think it's important to note that our current treatments are not based on an understanding of neurobiology. We do have opportunities there. I didn't talk about circuit-based treatments that I think are promising, and I noted that others are talking more about biomarker-based subgrouping and interventions. But I do want to just highlight again the hope that we can put interventions together and then pause and take questions.